Management major trauma. Pre-hospital force, several bleeding, take first aid steps, and research the injured person. Remove any clothing or debris on the wound. Don't remove large or deeply embedded objects. Don't probe the wound or attempt to clean it yet. Your first job is to stop the bleeding via disposable protective gloves if available. Place stop the bleeding. Place a sterile bandage or clean cloth on the wound. Press the bandage firmly with your palm to control bleeding. Apply constant pressure until the bleeding stops. Maintain pressure by binding the wound with a cheek bandage or piece of clean cloth. Don't put direct pressure on an eye injury or embedded object. Secure the bandage with adhesive tape or continue to maintain pressure with your hands. If possible, raise an injured limb above the level of the head. Hot. Help the injured person lie down. If possible, place the person on a rug or blanket to prevent loss of body heat. Calmly restore the injured person. Don't remove the gauze or bandage if the bleeding seeps through the gauze or other clothes on the wound. Add another bandage on top of it and keep pressing firmly on the area. Tourniquets. A tourniquet is effective in controlling treating bleeding from a limb. Apply a tourniquet if you're trained in how to do so. Tourniquet is a device that is used to apply pressure to a limb or extremely in order to limit but not stop the flow of blood. It may be used in emergencies, in surgery, or in post-operative rehabilitation. Also, a tourniquet is used by the phlebotomist to assess and determine the location of a suitable vein for venipuncture. Proper application of a tourniquet will partly impede venous blood flow back toward the heart and cause the blood to temporarily pool in the vein, so the vein is more prominent and the blood is more easily obtained. There are four types of tourniquets: surgical tourniquets, emergency tourniquets, rehabilitation tourniquets, and a tourniquet is used by the phlebotomist to assess and determine the location of a suitable vein for venipuncture. Emergency tourniquets are cuff-like device designed to stop severe traumatic bleeding before during transport to a care facility. They are wrapped around the limb proximal to the site of trauma and tighten it until all blood vessels underneath are occluded. The design and construction of emergency tourniquets allows quick application by first aid responders or the injured persons themselves. Correct use of tourniquet device has been shown to save lives under austere conditions with comparatively low risk of injury. In field trials, prompt application of emergency tourniquets before the patient goes into shock associated with higher survival rates than any other scenario where tourniquets were used later or not at all. Existing guidelines call for the use of improvised rope and stick. Tourniquets as a last resort to stop severe bleeding. However, purpose-made tourniquet devices that are well designed can provide greatly increased safety and efficiency. Variability in performance has been shown to exist between various designs and application methods. Mechanisms that confer sufficient mechanical advantage are essential for applying adequate pressure to stop bleeding, particularly on the lower extremities. Pressures that occlude venous but not arterial flow can exacerbate hemorrhage and cause damage to healthy tissue. Results from laboratory and field testing suggest that windlass and pneumatic mechanisms are effective where other systems fail due to excessive pain, slipping, inadequate force, or mechanical failure. Pressure determines a tourniquet cuff is not evenly distributed, with the highest pressure localized around the cuff centrally and decreasing to zero near the cuff edges. A high rate of change of pressure across the cuff width or a high cuff pressure gradient is a leading cause of nerve and muscle injury from tourniquet use. Tourniquets with wider stripes of cuffs or cuffs, especially those with pneumatic actuation, in contrast to mechanical force, distribute pressure more evenly and produce low pressure gradients. They are therefore more likely to stop bleeding and less likely to cause damage to underlying tissue. In addition to being significantly less painful than tourniquets with narrow straps and bands. Overpressure protection in certain emergency tourniquets also help to prevent excessive force from damaging the limb. Possible risks of complications, morbidity related to emergency tourniquet use include amputation or storing, palsy, myonecrosis, pain, clot, fasciotomy, acute renal failure, rigor, abscesses, blisters, abrasions, continuance, and pinching. Emergency care service implementing routine tourniquet use, especially in the civilian setting, should exercise caution and ensure that training is adequate for optimal results. However, given proper precautions, the occurrence of complication due to tourniquet use is quite rare. Design tourniquet device routinely tightened our healthy limbs during training with no ill effects. And recent evidence from combat hospitals in Iraq suggests that morbidity rates are low when users adhere to standard best practices. Science to know better alternative exist for users to self-apply with only basic training. The benefit of tourniquet use for outweighs the risk. Safe tourniquet practice involves careful placement of tourniquet proximal to all sites of hemorrhage, limiting tourniquet time to less than 2 hours if possible, minimizing excessive applied pressure beyond the point of complete blood flow cessation. Another emerging need is more refined training regimes and doctrine based on scientific evidence, which can ensure that future tourniquet practice and policies are aligned with the most current body of knowledge. The Croc combat radio clamp is the first device for 7-side junctional hemorrhage control. Hemorrhage is the leading cause of preventable death on the battlefield. Approximately 25% of potential survivable military deaths due to uncontrolled junctional hemorrhage, the majority of which occur in the pelvic region. When fall, limb amputation occur in a tactical environment, standard tourniquets cannot be used. The Croc Combat Ready clamp is the solution. Unlike an inflatable belt-like device, the Croc has a vise-like compression disc that provides the distinct life-saving advantage of creating bidirectional pressure exactly where it's needed most, stopping collateral flow and controlling hemorrhage. The Croc is lightweight, durably collapsible, low cube, and can effectively stop junctional hemorrhage in under a minute. In a crisis, seconds matter. Death by bleeding from a gunshot blast happens in just uh, 5 minutes, and saving lives needs fast, urgent action. Emergency responders take on the burden of getting their patients to hospital alive and in the best state possible for surgery and recovery. Silex trauma products are first-line emergency treatments used immediately after injury and during the transfer to hospital. The Silex trauma range includes Silex Advanced dressing to stop life-threatening bleeding hemostatic agents, designed for EMC providers. Silex EMC is a fast action economical solution for bleeding injuries. Fox Seal, the dependable chest seal in a compact pack. A Fox Seal chest seal is a pioneering occlusive dressing for the treatment of open chest wounds as a tool in prevention of pneumothorax. Compact first effect without folding to avoid creases. Strong adhesion in extreme conditions. 2-pier pack for ballistic wounds. Simple non-valve design went with large, easily to operate tap. Other dressing options are often folded when carried in kits, leading to a permanent crease, which can prevent a true seal. Fox Seal is a compact size to fit neatly into patches to avoid creasing. 2 seals per pack alone in tray and exist wounds to be treated. Patient monitoring is vital in these injury types, and the design is a simple, well-free option for simple use. The chest can be vented with the easily gripped tab and the adhesive reseals. Silex A. Penetrating injuries such as blast of knife wounds are very difficult to treat, and other lethal. Silex I is a unique hemostatic granular applicator packet with 6 grams of Silex granules and designed to get through a small entry wound directly to the bleeding site in just a few seconds. A unique high-speed applicator treats narrow wounds, bullet blast fragments, and stab injuries, gets to the source of the bleeding. Uh, The IT clamp by innovative trauma care represents the latest advance in battlefield hemorrhage control, the leading cause of preventable combat deaths. For self-aid or body aid, it is an intuitive, easy to apply, combat-ready wound closer device that controls several bleeding within seconds of application during care under fire. Virtually painless, the IT clamp seals the wound, creating localized hands-free pressure that quickly forms a stable clot and prevents future blood loss. Localized pressure remains the simplest time test way to control severe hemorrhage. Application of the IT clamp is intuitive and with minimal training. Every warfighter can instantly treat life-threatening hemorrhage, not amenable to a tourniquet. A bone fracture is a medical condition in which there is a partial of or complete break in the continuity of the bone. In more several cases, the bone may be broken into several pieces. A bone fracture may be the result of high force impact or stress, or a minimal trauma injury as a result of certain medical conditions that weaken the bones, such as osteoporosis, osteopenia, bone cancer, or osteogenesis imperfecta, where the fracture is then properly termed pathological fractures. Also, bone tissue contains no pain receptors. A bone fracture is painful for several reasons. Breaking in the continuity of the periosteum with of or without similar discontinuity in endosteum, as both contain multiple pain receptors. Edema and hematoma of nerve layer for soft tissue caused by ruptured bone marrow invokes pressure pain. Involuntary muscle spasm trying to hold bone fragments in place. Damage to adjacent structures such as nerves, muscles, or blood vessels, spinal cord, and nerve roots for spine fractures or cranial contents for skull fractures may cause or other specifics, signals and symptoms. Both high and low force trauma can cause bone fractures, injuries. Preventive efforts to reduce motor visually crashes, the most common cause of high force trauma, include reducing distractions while driving. Common distractions driving under the influence and texting or calling while driving, both of which lead to an approximately six-fold increase in crashes. Wearing a seat belt can also reduce the likelihood of injury in a collision. first aid of fractures, stop bleeding, especially in the case of open fractures where the skin is torn by wrapping the wound with sterile bandage or clean clothes. Avoid moving the affected area. Any movement can result in serious complication, especially in the case of neck and back fractures. Cool the affected area by applying an ice pack of or ice cubes wrapped in clean cloth. Call the ambulance and help the patient get to the emergency department for examination and treatment. If you suspect a fracture, you can apply splints. Use paddings between the body part and the splint. Make sure the circulation is not cut off. Use skin color, skin temperature, pulse oximetry, and your other assessment knowledge to determine perfusion status to the injured extremity. The splint should cover the joint above and below the fracture site. This gives added support to the splint and prevents movement of the joint and extremity and shifting of bone ends. The rule in EMC has long been to splint fractures in the position in which they are found, especially if the injury involves a joint. However, current textbooks recommend that except for joint injuries, extremities should be splinted in their correct anatomical position unless resistance is met when attempting to do so or there is a disruption caused to the patient circulation. During splinting, take care not to cause sharp bone and to move unnecessarily and re-enter the wound. This can cause future tissue or vessel damage and increased hemorrhaging. However, keep in mind that during proper splinting, bone ends frequently do re-enter the subcutaneous area on their own as the bone segments are religionate. There is nothing you can do to prevent this. If this does occur, be sure to advise the ED staff and not if it on your patient care report so they are aware of it and manage the patient accordingly. Bone and re-entry calls also happen along with nerve damage if you do not reposition the affected limb. Therefore, EMC personnel should defer to the agency protocols and medical directors' recommendation regarding the careful repositioning of fractures. Most orthopedic specialists feel that the anatomical position occurs when the body naturally risks to alleviate stress, exertion, and pain, and occur that reposition protects against future injury and makes the patient more comfortable. However, if you meet and any type of resistance during exposition stop the attempt the splint the extremity in the position found. Many pre-hospital providers think of splinting as a basic skill. However, for all providers, the basic skill of splinting takes talent and experience to be performed correctly. Failure to properly splint an extremity can lead to injury that worse than if you didn't splint it at all. Pelvic slings are now being used increasingly in the pre-hospital environment. Preliminary research shows that using a pelvic sling in unstable pelvic fracture in the pre-hospital environment is indicated and can help prevent future injury when transferring that pressure during extrication and transport. The splint, like the other, decrease the patient's pain associated with their injury. It remembers that the anatomy underneath this split is very susceptible to injury. Sudden shifting of the unstable pelvic ring can cause a tear in large blood vessels, thus causing hypovolemia, hypotension, and tachycardia and death. Treat the patient's shock, help them get into a comfortable position, encourage them to rest, and reserve them, cover them with a blanket or clothing to keep them warm. Pain management is something that many EMC agencies are working to improve, particularly when dealing with fractures. EMTC and paramedics have more pain management at their disposal than they often release. The splint itself does a good job of managing pain when properly applied, but sometimes the patient needs more than a splint. A good mnemonic to use in remembering some simple but often overlooked pain management techniques is rest, ice, compress, splint, and elevate. Ice is frequently forgotten analgesic. It may initially cause the injury to throb because it causes blood vessels to constrict, but it decreases the swelling of an injury and the pressure that swollen tissue exerts on the injury. Ice can also numb a sensitive nerve and often your patient more pain relief. Elevating a splinting extremity can also decrease painful throbbing and swelling. This results from a simple law of physicians. Blood has a harder time flowing uphill than down. Elevating and padding the injury with a pillow also decrease the amount of movement the injury sustains as the ambulance bounces, twists and turns and road to the hospital. along with sprinting, eyes elevation and positioning. The touch of another human being has been shown to reduce the anxiety level of patients in pain and should be used in conjunction with your research works. The actual medical term for the concept is the therapeutic touch. Also, simply talking with your patients and telling them your care is just as important as showing them the sprinting process. These are simple ways to decrease the anxiety and consequently decrease their pain. Pharmacological analgesics are also effective at reducing pain and K tool in the ALC toolbox. Morphine, Dilovit, fentanyl, and Toradol are options for pain management in many states. A common case of low force trauma is an at-home fall. To prevent at-home falls, they suggest keeping cars out of high traffic areas where someone could trip, installing hand rails and keeping stairways well lit, and installing an assistive bar near the bathtub and in the washroom for support. To reduce the impact of a fall, the NIH recommends to try falling straight down on your buttocks or onto your hands. Finally, taking calcium, vitamin D supplements can help strengthen your bones. Thank you for listening. Goodbye.